Hello students, today we are going to learn about stomach, which is also called venter or gaster. You know, stomach is also called as gaster. It is also called as venter. Okay, so from this word gaster you get adjectives like gastric ulcer, gastric artery, gastric vein. Okay, and you know this aspect is also called the ventral aspect. The back is called dorsal aspect, but this is called the ventral aspect. So that is all coming from the word gaster or venter. Okay, so stomach is a very English way of calling it. So once you call it gaster, now study of stomach and intestines is gastroenterology. Okay, now intestine is also called enteron. Okay, so you see the endoscope they put into the mouth to see the presence of ulcer in the stomach. What is the procedure called? Gastroscopy. Okay, from this word stomach we are having so many words now. Then coming to what exactly is stomach? Stomach is the muscular bag. It is the most widest and distensible organ of gastrointestinal tract. It is the most distensible. So as the person is going on eating and eating, he will become fat. Okay, that's what it is able to distend. The stomach can distend. Okay, and it is the most widest and the most distensible part of the gastrointestinal tract. Now because it is an abdominal organ, whenever we are going to describe its location, we have to exactly tell in which quadrants of the abdomen is the stomach present. The stomach is present in the epigastric, umbilical and the left hypochondriac region. The stomach is present in the epigastrium, umbilical and the left hypochondriac region. So we'll just try to draw is a rough diagram what I'm trying to draw so that you can have a understanding. They may not be anatomically perfect what I'm drawing. Okay, so here if you see we are trying to draw the stomach. Okay, so here we are just trying to draw the stomach. So here we are just trying to draw. So this is the epigastric region, this is the umbilical region, this is the right hypochondriac region. So right hypochondriac region. Are you understanding? So if you take the midline, and see this portion, that is the stomach starts from the cardiac orifice. Here it is the cardiac orifice. This is the esophagus. So above the stomach is continuous with esophagus. Okay, above the cardiac orifice, and below it has got the pyloric orifice. Now this is the pyloric orifice. Now this is the cardiac orifice. This is the cardiac orifice what you are seeing. Okay, now if you see the stomach from the midline, it is about 2.5 centimeters from the midline, you know, from the sternum. If you are trying to take the measurement, it is about 2.5 centimeters to the left. And if you see the pyloric part of the stomach, that is about 1.2 centimeters to the right. 1.2 centimeters to the right we have got the pylorus, and 2.5 centimeters towards the left side we have got. Okay, now why should you know this? See, whenever people they are eating lot of spicy curries, okay, or too much of mirchi, you know, when they are eating, what happens? They get the reflex esophagitis. So the food which is present in the stomach, you know, because of lot of spice and all, it causes pain along the left portion of the chest, just by the side of the esophagus. So the patient is coming to the hospital telling this whole portion is paining. So we should take in the history whether is it pain or whether it is burning sensation. You understanding? Because cardiac problem also will have pain, but here it is not just pain, it is first burning sensation and then that is associated with the pain. Okay, so you should understand whether that is called heartburn. Heart is not burning, it is only the portion which is more towards the left side, it is causing that is the esophagus, the lower end of the esophagus, and this portion of the stomach, that is all having the burning sensation, which you call it as heartburn. So if a person more than 45 or 40 years of age have come to your emergency telling in the night 10 o'clock or 11 o'clock this portion is paining, 100% you have to take ECG, and once ECG is normal, then you will realize, the patient will tell, no, it is not pained, it is burning. I have eaten a lot of spicy curries, lot of masala was there, chili was there, and that's why it is paining. Okay. And another thing, when there is obstruction of the pylorus, when there is obstruction of the pylorus, you see visible peristalsis in the region of epigastrium. So this upper portion, this region, epigastrium, above the umbilicus, whatever is present is called above the umbilical region, whatever present in the center is called epigastric region. There you can see visible peristalsis in case of pyloric obstruction. Okay. So now let us try to learn about the stomach in detail. What are the gross features of the stomach? The gross anatomy, let us learn. The lucky number of stomach is 2. Please understand, 2 is its lucky number. It has got 2 surfaces, anterior and posterior. It has got 2 borders, right border and the left border. The right border is also called lesser curvature. The left border is also called greater curvature. It has got 2 orifices, cardiac orifice, pyloric orifice. It has got 2 sphincters. Please listen, it has got 2 sphincters physiologically. Okay. Only one sphincter is demonstrable both anatomically and physiologically, and that is the pyloric sphincter. So now let us try to learn about the gross anatomy of stomach. So here we are trying to draw the esophagus. Okay. And here is the cardiac notch, and that is the greater curvature of the stomach, and this is the lesser curvature of the stomach, and here we have got the pylorus, which is opening into the, or that is getting continuous with the duodenum. So this is the duodenum and this is the esophagus. So stomach is continuous with the esophagus above, okay, and stomach is continuous with the duodenum below. Now here what I am trying to draw is the lesser curvature, and this is the greater curvature. The greater curvature is 5 times larger than the lesser curvature. And when the person is going on eating and eating, he is becoming fat. Here the greater curvature is showing the extension. Okay. If you see the stomach, in case of sthenic people, that is who are average, moderately built and who are active, in them the stomach is more or less J-shaped. Whereas in hyposthenic people, it is absolutely J-shaped, vertical and almost J-shaped. But in people who are robust, who are obese, in those people, that is hyperesthenic you can call. In this hyperesthenic people, it is horizontally placed. The stomach is horizontally placed, something like this. It is placed more or less horizontally. In the hyperesthenic people, that is obese or robust people, stomach is more or less horizontal. Okay. So that's how you have to understand about how the stomach is present in its orientation. And coming to the capacity of the stomach, in newborn it is just 30 ml or 1 ounce. In case of young adults, it will increase up to 1 liter. Okay. And still a man is going on eating, he had crossed his adolescent age and now he is adult, it can go up to 1.5 to 2 liters. So the capacity of the stomach from 30 ml at the time of birth, it will increase to 1 liter in the adolescent to 1.5 to 2 liters. It can increase. Okay. So we are trying to talk about the curvatures of the stomach. So we said there are 2 curvatures, okay, and they are the lesser curvature and the greater curvature. The lesser curvature is small, whereas greater curvature is 5 times larger than the lesser curvature. Okay. Now it has got 2 orifices. This portion is called the cardiac orifice, which is joining it with the junction of esophagus. So this is the cardiac orifice, and that which is joining it with the duodenum here. So this is called the pyloric orifice of the stomach. Please understand, when the food is passing through the esophagus into the stomach, many times it is being found out that there is a sphincteric action, but physiologically demonstrable. Here there is definitely the movement of the food into the cardiac end of the stomach is in such a style that they are telling there is a physiological sphincter, but there is no anatomical sphincter. Anatomically you don't have any sphincter here. Now what is anatomical sphincter? The circular muscle coat, the circular smooth muscles, they form a very thick muscle coat here, okay, and that is at the region of pylorus, and this is called the pyloric sphincter. So they say the pyloric orifice is beautifully demonstrating both anatomical and physiological sphincter. So if you hold the pyloric part of the stomach between your thumb and other fingers, very beautifully you will feel that nodular feel, as if something muscular and hard is there, something muscular and very hard, you can feel it once you are trying to roll between your thumb and the other index and the middle finger. You can feel the nodular feel of the pyloric sphincter. Okay, now from the lesser curvature, if you see, there is one most dependent area. From the most dependent part, when you draw a line towards the greater curvature, this dependent part of the lesser curvature angularis, it is called incisura angularis, or it is also called angular notch. So from this angular notch, when you draw a line towards the right side, cutting the greater curvature of the stomach, so that is dividing the stomach into two parts. They are the cardiac part, and below that is the pyloric part. So how many parts are there? Cardiac part and the pyloric part. Please observe, starting from this cardiac notch, now you see this is the greater curvature and it shows a cardiac notch. From the cardiac notch, when you draw a line horizontally towards the greater curvature, then what do you have? You are having the fundus. So here you are having the fundus, and below the fundus you have got the body. So if they ask you what are the two parts of the cardiac part of stomach, they are the fundus and the body. This portion, fundus, in X-rays it is seen under the left dome of the diaphragm, and it is filled with air. It is blackish in color, it's filled with the air, the fundus. Okay, below that you have got the body. So these are the two subdivisions of the cardiac part. Now coming to the pyloric part, please observe, along the greater curvature of the stomach, along the greater curvature, there is a constriction called sulcus intermedius. Sulcus intermedius. This sulcus intermedius is an inconstant sulcus. It is not seen distinctly every time. Sometimes you can see this. From this sulcus intermedius, when you drawing a line towards the lesser curvature, when you are drawing, so that will divide this pyloric part into a pyloric antrum and pyloric canal. So you are having the pyloric antrum, and you said this is the pyloric canal. Okay, so you have got two parts for the cardiac, fundus and the body, two parts for the pylorus, pyloric antrum and the pyloric canal. If you see the entire length of the stomach, it is about 25 centimeters. Up to the body, it is about 15 centimeters. The pyloric antrum and pyloric canal. The pyloric antrum, it may be measuring up to 7.5 centimeters, and the pyloric canal about 2.5 centimeters. And you know, this canal is guarded by the pyloric sphincter. So here the sulcus intermedius, what you are seeing, is not constant. Sometimes it is present very clearly, and sometimes we have to imagine, okay, the sulcus intermedius, because it is not always present. So that's how you are having the pyloric antrum, the pyloric canal. And this lesser curvature is also called the right border of the heart, and the greater curvature is also called the left border of the heart. It's also called the left border of the heart. Peritoneal relations. Now we are going to learn the peritoneal relations of the stomach. So the peritoneal relations. You know the stomach. Just try to draw. It's got a lesser curvature, it's got a greater curvature, it's got an anterior surface, and it also has got a posterior surface. Anterior surface and a posterior surface. So there is peritoneum which is covering both the anterior and the posterior surfaces. There is the peritoneum which is covering the anterior and posterior surface. Along the lesser curvature, it is being reflected, in the form of the lesser omentum. So you feel the lesser omentum along the lesser curvature. And here if you see along the greater curvature, you are able to appreciate the greater omentum. So that is the lesser omentum which is attached to the lesser curvature, and this is the greater omentum which is attached to the greater curvature. The greater omentum, it hangs down like a apron, okay, from the greater curvature of the stomach. Now you know very close to the stomach there is spleen that is present. So the peritoneum which is extending between the stomach and the spleen. So this is the gastrosplenic ligament. This is the gastrosplenic ligament what you are having, and above here this you have got a ligament which is connecting this with the muscular diaphragm. So the stomach and the diaphragm, it is extending between the stomach and the diaphragm, and that is called gastrophrenic ligament. Phrenic means diaphragm. So this is the gastrophrenic ligament. So you are having gastrosplenic between the stomach and the spleen, gastrophrenic between the fundus of the stomach and to the left crus of the diaphragm is the gastrophrenic ligament. Now if you see this area of the fundus which is above this gastrophrenic ligament, it is directly related to the diaphragm, and this is called the bare area of stomach. The bare area of stomach is that portion of the stomach which is in direct contact with the diaphragm, that is present above the gastro or medial to the gastrophrenic ligament. Okay, so that is the bare area of the stomach. Also if you see the lesser curvature and the greater curvature of the stomach, they are present in between the two layers. So these borders are also not having any peritoneum. Okay, they are not they are also bare, these two, that is the greater curvature and the lesser curvature. So in fact this curvatures are sandwiched between the two layers, anterior layer and the posterior layer. So these margins, they are not really attached to any of the layers, just above them and below them you have got the layers of the peritoneum. So these are also bare, but when it is asked about bare area of stomach, we specifically answer that portion of the stomach, that is the posterior surface of the stomach near the fundus above or medial to the gastrophrenic ligament, that is in direct contact with the diaphragm, is called the bare area of stomach. That's what we answer. And now coming to the visceral relations. So what are the visceral organs which are in close association with the stomach means, anteriorly if you see, anteriorly obviously anteriorly it is the left lobe of the liver that is present. Anteriorly it is the left lobe of the liver to which the stomach is related. Of course we also have the anterior abdominal wall, partly diaphragm. So basically the visual relations of the anterior surface of the stomach, if you see, you have got the left lobe of the liver, the muscle, the anterior abdominal wall, and partly the diaphragm. Now coming to the posterior surface, the posterior surface of the stomach is related to so many structures which is called as stomach bed. Okay, so we are calling it the stomach bed. So when you are talking about the stomach bed, what are the structures which are forming the stomach bed? The stomach bed here, you have the kidneys, okay, the left kidney obviously because it is present on the left side, the stomach is present on the left side. This is the left kidney, okay, and you have got the left adrenal gland or the suprarenal gland, the left adrenal gland or the suprarenal gland. Then you have got the pancreas which are present, the pancreas which are present, okay, and you know the hilum of the pancreas is extending up to the hilum of the spleen. The tail of the pancreas is extending up to the hilum of the spleen, okay. Then you have got the, what is this I am trying to draw? I am trying to draw the transverse. This is the transverse colon, okay. This is the splenic flexure of the colon, okay, and here you have got the transverse mesocolon. So this is the transverse mesocolon. The transverse mesocolon is what you are having here, okay. So, and you know the pancreas, what is the blood supply? Remember the splenic artery which is tortuous, it's also reaching up to the hilum of the spleen. So this is your splenic artery, okay. So what are the structures which are forming the stomach bed if they ask you? And one muscular, that is the diaphragm, the left crus of the diaphragm. Now what are the structures which are forming the stomach bed? You know the mnemonic Dr. S, that is S4, kills patients mercilessly, right? Doctor S4 kills patients mercilessly. So doctor, D is what? Diaphragm, the left crus of the diaphragm, okay. Then S, there you have got 4 S's. One is the left suprarenal gland, spleen, splenic artery, splenic flexure of colon, okay. Then you have got the left kidney, then you have got the pancreas, and then you got the transverse mesocolon. So these are forming the structures of the stomach bed. Also you please understand here the structures which I have told, except spleen, except the spleen, all the structures are separated from the stomach by lesser sac. Some people they say no, spleen is not forming the stomach bed because it is separated by greater sac. The spleen from the posterior surface of the stomach is separated. The spleen from the posterior surface of the stomach is separated by the greater sac, the cavity of the greater sac. Whereas these other structures like the diaphragm, the suprarenal gland, the spleen, the suprarenal gland, the splenic flexure of colon, the pancreas, the splenic artery, transverse mesocolon and transverse colon, these are separated by the cavity of lesser sac. So there is some difference of opinion, but if you are not including spleen, it will become S3. But if you say no, I will include spleen, it will become S4, okay. So the cavity of lesser sac is separating the posterior surface of the stomach from, so this cavity of the lesser sac is separating the posterior surface of the stomach from these structures that are forming the stomach bed. Now please understand here when we are trying to talk about these peritoneal relations, you know this portion of the costal margin, the costal margin is extending over the fundus of the stomach, the left costal margin. The left costal margin is extending here. So here you please understand, when you are trying to percuss over the left costal margin, when you are percussing, the resonant note is what do you get? You get a resonant note. Why you get resonant note? Because of the presence of this fundus, which is filled with air under normal condition, and that is called trough-base space. So what is it called? Trough-base space. So they will ask you as 2-mark short note, what is trough-base space? So you will tell the fundus of the stomach is covered by the left costal margin, and when you are percussing over the left costal margin, that portion which is present over the fundus of the stomach will give a resonant note. That is what you call trough-base space normally. But if there is enlargement of spleen, imagine if there is splenomegaly. If there is splenomegaly, then this resonant note will miss because the spleen had enlarged. Also, if there is pleural effusion on the left side. So what are the conditions? If there is splenomegaly, that is enlargement of the spleen, and if there is pleural effusion, on the left side, so during these two conditions, what is happening? When there is splenomegaly and pleural effusion, when the doctor is percussing, the note will be dull because it is showing some pathology. And what is that area? Area is called trough-base space. Okay, so this you should keep in mind. So we have finished about the relations of the stomach, the visceral relations and the peritoneal relations. The visceral relations are anteriorly what you have? The left lobe of the liver, anterior abdominal wall, partly you have got small portion of the diaphragm. But posteriorly, these are the structures which are forming the stomach bed. Okay. Now let us now go with the blood supply of the stomach. Blood supply of the stomach. Okay. So just let us try to draw the outline. So that is the outline of the stomach we are trying to draw. So now let us begin the blood supply. You know the artery of foregut is celiac trunk. Okay. So this is the celiac trunk. From the celiac trunk there is one large tortuous artery. Now I am drawing in dotted line. You can understand it is going posteriorly. Just now we learned the stomach bed. One of the important constituents are the splenic artery. So the splenic artery here, okay, it is going towards the spleen, the hilum of the spleen. It is extending. Okay. So this splenic artery gives 5 to 6 short gastric branches to the fundus of the stomach. So these are the short gastric arteries which are supplying the fundus of the stomach. Then you have got artery which is supplying the greater curvature of the stomach, a portion of the greater curvature of the stomach, and that is the left gastroepiploic artery. This is the left gastroepiploic artery. Okay. Now the splenic artery here you have seen is giving the left gastroepiploic artery which is running downwards along the greater curvature. It gives 5 to 6 short gastric arteries which are supplying the fundus of the stomach. This celiac trunk also gives an artery which is called the left gastric artery, which is running towards the esophagus, but it takes a U-turn, descends down along the lesser curvature. So this is the left gastric artery. In fact, it is running down, okay, towards, it is running down along the lesser curvature of the stomach, okay. And you please see the celiac trunk gives one artery called common hepatic artery. What is this artery called? Common hepatic artery. Okay. This common hepatic artery gives to two branches. This is the proper hepatic artery. This is the proper hepatic artery. Okay, and you have got another one, that is the gastroduodenal artery. So this is the gastroduodenal artery. Please look at the board. Here is the gastroduodenal artery. From this gastroduodenal artery, you get an artery which is running towards the greater curvature of the stomach, and this is called the right gastroepiploic artery. The right gastroepiploic artery, okay, which is anastomosing with the left gastroepiploic artery and supplying the greater curvature of the stomach. So the greater curvature of the stomach is supplied by the left gastroepiploic artery, which is a branch of splenic artery, and then the right gastroepiploic artery, which is a branch of the gastroduodenal artery. Now if you look at this proper hepatic artery, the proper hepatic artery gives a branch called the right gastric artery, which is anastomosing with the left gastric artery along the lesser curvature of stomach. Okay, so along the lesser curvature you are having the left gastric artery and the right gastric artery. The left gastric artery is a branch of celiac trunk, the right gastric artery is a branch of proper hepatic artery. So that's how you are having the anastomosis here of the blood vessels along the lesser curvature and along the greater curvature of the stomach. Are you able to appreciate the blood supply? Now, blood supply is not over if you don't speak about the venous drainage. Okay, now coming to the venous drainage, you know we have got the splenic vein, which is again present on the posterior surface of the stomach. So here you are having the splenic vein. Okay, this is the splenic vein, and here you have got the superior mesenteric vein. So here we have got the superior mesenteric vein. Into the splenic vein you have got the left gastroepiploic vein opening, and you have got the short gastric veins which are opening into the splenic vein. The right gastroepiploic vein drains into the superior mesenteric vein. The splenic vein and the superior mesenteric vein unite to form which vein? Portal vein. Okay, this portal vein is opening in the liver. Now we have made separate videos for the portal vein, also for the spleen. You can see if you want to learn more. Okay, so here you are having the left gastroepiploic vein opening into the splenic vein. You have the right gastroepiploic vein which is draining into the superior mesenteric vein. Okay, this superior mesenteric vein and splenic vein unite to form the portal vein, which is entering the substance of the liver. Okay, via the porta hepatis, dividing into right and left branches. Is that fine? You are able to follow? Good. Now let us study about the interior of the stomach. This you should understand when you are talking about the interior of the stomach. Here the stomach has got three layers of muscle coat. There are three. Innermost is the oblique layer, which is more towards the fundus. Okay, so here is the oblique muscle coat, and it is present all over the stomach. Okay, and the middle one is the circular muscle coat. So in the middle you have got the circular muscle coat, which is present along the entire length of the stomach, and the outermost is the longitudinal muscle coat, specially seen along the curvatures. And especially if you see the lesser curvature, you can beautifully appreciate the interior of the stomach. How will you appreciate the interior? You will cut along the greater curvature in the dissection hall and you will reflect the flap. Then what you get? The longitudinal muscle coat, which is very beautifully seen along the lesser curvature. This longitudinal muscle coat is arranged in such a style, it forms gastric canal. This gastric canal is also called Magenstrasse, German Magenstrasse. Megan's trace, it is also called as this longitudinal, this gastric canal, which is formed by the longitudinal muscle cords specially. There are, now please understand, there is something called water therapy for constipation. What is water therapy? The moment the person gets up in the morning from sleep, he has to drink minimum 1.5 to 2 liters of water. When they drink so much of water, what will happen? The water will directly enter the stomach in the lesser curvature. Along the lesser curvature, it will go into the duodenum and into the jejunum, ileum, and it is initiating the bowel movement. You're understanding? When you drink in sips, like you take one glass of water and slowly you are taking small sips, what will happen? When you take small sips, then the water will enter here and it can get into the interior of the stomach. But if you are drinking liters, like 1 liter or 2 liters at a stretch, okay, continuously when you are drinking, so the water is not really entering into the cavity of the stomach which is present along the greater curvature, but it is rushing down into your small intestine, duodenum, jejunum, ileum, from there into the large intestine, and it will initiate the bowel movement and the person will be going for his nature call. Are you understanding? So that is the importance of this arrangement of the longitudinal muscle cord. We have taught in histology about the layers, the mucosa, the submucosa, then the muscular layer, all those things. So there is a separate video on the histology of stomach, so that you can learn. That you can see and you can learn if you are interested. And coming to the lymphatic drainage, which is very important. Now please understand, let us try to vertically divide the stomach into right 2/3 and left 1/3. Again, this left 1/3 you are dividing into upper portion and lower portion. Okay, so that is upper portion, that is the left 1/3 upper part, this is the lower portion, the left side. Okay, and here you know you have got the pylorus here, the pyloric sphincter. So this is the other portion. So please observe, we have got the lymph nodes which are called celiac lymph nodes. Now what are these? These are the celiac lymph nodes. Then you have got the left gastric lymph nodes. I am using the green color. And you are also having the hepatic lymph nodes. So these are the hepatic lymph nodes, the celiac lymph nodes, and this is the left gastric lymph nodes. Okay. The right 2/3 of the stomach drains into the left gastric lymph nodes, and this portion, this entire right 2/3, it is draining into the gastric lymph nodes. From the gastric lymph nodes, it is drained into the celiac lymph nodes. Okay. Now if you see this left 1/3 more towards the fundus and along the greater curvature, this entire portion is draining along with the splenic vein. It is draining into the celiac plexus of lymph nodes. It is draining into the celiac plexus of lymph nodes. Now this lower portion, the left side, the lower portion is drained into the gastroepiploic lymph nodes. From the gastroepiploic lymph nodes, the lymph is coming into the pyloric lymph nodes. Now let us learn about the interior of the stomach. In histology, we have taught in detail about the mucosa, submucosa, the muscular layer and the serosa. Just relevant to our gross anatomy topic, I would like to tell about the interior of the stomach. Okay, so here we will just go with drawing the stomach. That's the esophagus, this is the lesser curvature. Yeah, that's how we have drawn. The duodenum is the. So if you see the interior of the stomach, now how will you see the interior of the stomach? You will cut along the greater curvature and reflect. Okay, you will reflect the flap, and that's how you will see the interior of the stomach. You see there are lots of mucosal folds present, and these mucosal folds are irregular along the greater curvature and the other parts of the stomach. These are irregular, the mucosal folds, which are called rugae. Okay, so you have got the rugae, the mucosal folds. But along the lesser curvature, if you observe, along the lesser curvature, the mucosal folds, they form a gastric canal. So this is called the gastric canal, which is formed by the mucosal folds. Okay, along the lesser curvature, predominantly you will see. And these mucosal folds are arranged in such a style, they are called gastric canal, or also called as Megan's trace. Megan's trace, one more name. Okay, so these gastric canals, these mucosal folds, they are, please understand, we have got with the mucosa. Okay, we are trying to describe this mucosa along the lesser curvature. Then you have got the submucosa. Then you have got the muscle coat, the muscle layer. If you observe the muscle layer of the stomach is having three layers. What are they? They are innermost, which is, then the middle, then the outermost. The outermost layer is the longitudinal muscle layer. The middle is the circular muscle layer. The innermost is the oblique muscle coat. Okay, so if you see the lesser curvature, along the lesser curvature, here the innermost oblique muscle coat which is present, the contraction of these muscles will make this gastric canal much deeper. Please understand, when you are talking about the muscle coat, we have got the outer longitudinal, middle circular muscle coat, innermost is the oblique muscle fibers. The oblique muscle fibers, they are present in the region of the fundus, and also they are extending up to the greater curvature. These are all areas of the stomach where you definitely have the oblique muscle coat. You are having the longitudinal muscle coat, the circular muscle coat, and the oblique muscle coat. But please appreciate, the oblique muscle coat is present along the lesser curvature of the stomach in such a style that gastric canal becomes very prominent once these oblique muscle fibers, they contract. The oblique muscle fibers, once they contract, the gastric canal becomes very, very prominent, so that when any fluid enters here into the lesser curvature of the stomach, it will enter the gastric canal and it moves into the intestines. Are you able to follow what exactly we are trying to talk? Please understand, for constipation, a person if he is suffering from constipation, what people are telling? They have to go for water therapy. What is water therapy? The moment somebody gets up early in the morning, 5 o'clock or 6 o'clock, the moment they get up, they have to drink 2 liters of water minimum. Maybe 2.5 to 3 liters they can drink. So what will happen if they drink? So whenever you are drinking water in the form of sips, you take a glass, sip, keep the glass down, then again sip, what's happening? The water will enter, no doubt, into the stomach up to the lesser curvature, and it is just dispersed into the cavity of the stomach. But once a person is drinking liters and liters of water, what is happening? The water will enter along the lesser curvature it will enter the stomach along the lesser curvature. Because there is a gastric canal, it will go into the duodenum, jejunum, ileum, it will go into the intestines of the stomach, and it will cause the bowel movements. Are you understanding? From small intestine, it will go into the large intestine, and the person has to attend his nature call. Are you understanding the mechanism why they are telling you to drink water early in the morning once you get up if the patient is having constipation, so that you can initiate the bowel movement in the patient because of the water that will quickly travel down the gastric canal which is present along the lesser curvature of the stomach. Okay, and if you see the other areas where you have got these rugae, which are the mucosal folds that are irregular, you have got small pits. These are called the gastric pits. These gastric pits, you can appreciate them very beautifully if you are having a hand lens. You have got gastric glands, and these gastric glands are opening onto the surface of the stomach through this gastric pits. Okay, and you know the body of the stomach is having those chief cells, peptic or oxyntic cells, and if you take the pyloric part of the stomach, it is having the mucus cells in plenty. Okay, so we have taught in histology of stomach, so those videos, if you are interested to learn more, you can see. But here I just wanted to tell the significance of the gastric canal, how it is basically formed by the mucous membrane but made deeper by the contraction of the oblique muscle fibers and enabling the water, whatever you are drinking, to go directly into the intestines, okay, and initiating the bowel movement. Now we will learn about the lymphatic drainage of the stomach. So let us go with the lymphatic drainage of the stomach. Now let us go with the outline of the stomach. Okay, now this is the outline which I am trying to draw. Now please see, we have to divide the stomach into right 2/3 and left 1/3 by an imaginary line. So that's imaginary line which is dividing the stomach into right 2/3 and left 1/3. Okay, we are dividing it longitudinally, and here you have got the pylorus. This portion is the pylorus. Okay, now please observe, you are having here in the center celiac group of lymph nodes, or the celiac nodes you can call them. These are the celiac nodes, and you have got the hepatic nodes. So these are the hepatic nodes. You have got here the left gastric lymph nodes. These are the left gastric or gastric lymph nodes, you can tell. Gastric lymph nodes, you can make them gastric lymph nodes. Underneath the pylorus again you have got lymph nodes which are called underneath or below. So they become subpyloric lymph nodes. And here you have got the right gastroepiploic lymph nodes. Right gastroepiploic lymph nodes. Okay, here, and here you have got behind the posterior surface of the fundus the pancreatico-splenic lymph nodes. So here you have got the pancreatico-splenic lymph nodes. And now coming to the left 1/3 of the lower portion of the stomach, which is draining into the right gastroepiploic lymph nodes. From the right gastroepiploic lymph nodes, the lymph drains into the subpyloric group of lymph nodes. From the subpyloric group of lymph nodes, they drain either into the hepatic group of lymph nodes or into the celiac group of lymph nodes. Now coming to the right 2/3, this region, the right 2/3 which is along the lesser curvature and the anterior portion, this is supplying, or this is drained into the gastric lymph nodes. From this gastric lymph nodes, again it is going into the celiac lymph nodes. Coming to the pyloric portion, this pyloric portion is draining into the subpyloric region, a part of it. A part of it is draining into the hepatic region directly. From hepatic, it will again go into the celiac group of lymph nodes. Some are going into the celiac lymph nodes directly. So please understand, here in the region of the pylorus, some are directly going into the celiac group of lymph nodes. Good. But if they are drained into the subpyloric group of lymph nodes, no problem. From the subpyloric group of lymph nodes, they will be drained into the hepatic lymph nodes and then again into the celiac lymph nodes. Or if some of them are draining into the hepatic lymph nodes, again they will drain into the celiac lymph nodes. Are you able to follow? The most important and the final lymph nodes which are draining the stomach are the celiac group of lymph nodes. You are understanding? So this you should keep in mind, because there is something called Troyer's sign. So what is Troyer's sign? They will ask you in exam if you are answering very well, only to give you more marks. Please understand Troyer's sign. You know, we have learned about thoracic duct in detail, and we said thoracic duct start from cisterna chyli, it ascends upwards where it is towards right of the vertebral column at the region of fourth thoracic vertebra. It moves from right to left side, then ascends up finally to open at the region of the seventh cervical vertebra on the left side at the junction of internal jugular vein and the subclavian vein. Do you remember that? Because the celiac veins, they open into the cisterna chyli, they drain into the intestinal lymph trunk, which is opening into the cisterna chyli, and here you got the thoracic duct. So the thoracic duct is opening, okay, it is crossing over from the right side to the left side at the region of T4, remember, and it is ascending up and arching over at the region of C7. It will open into the junction of where internal jugular vein ends. Yes, are you able to get this diagram of the thoracic duct? The cancers of the stomach, the cancer cells will travel from the celiac group of lymph nodes into the cisterna chyli, okay, cisterna chyli, which will enter the thoracic duct, and from there it will go into this junction between the internal jugular vein and the subclavian vein, and here you have got the clavicle. Above the clavicle you have got the lymph nodes. So these lymph nodes which are present above the clavicle, the left supraclavicular lymph nodes will enlarge, they will become stony hard. So when the person is taking bath, or when the person is trying to feel there's something hard, he is feeling it, the region of the clavicle, above the clavicle, the supraclavicular region, something hard, something stony, something very firm nodule. What is this? I am not having earlier, now I am developing something. Then he goes to the doctor. Then the doctor will go for scanning of the abdomen. Are you understanding? The patient went to the doctor with the problem in the region of the left supraclavicular area. But the doctor is telling we will scan the abdomen. Why? Because the primary cancers of the abdominal organs can travel to the region of left supraclavicular area via the thoracic duct. And if you see the stomach very beautifully, you can understand. So even if you see there is cancer of the liver is drained by this hepatic lymph nodes. From hepatic lymph nodes, it will go to the celiac lymph nodes. From celiac lymph nodes, it will go to the intestinal lymph trunk, which is going into the cisterna chyli, and from cisterna chyli into the thoracic duct, and finally it goes with the left supraclavicular lymph node, which is also called as signal lymph nodes. The signal nodes or the signaling lymph nodes. Now what are they signaling? They are signaling about the cancer which is present in the abdomen. So the primary site is one of the abdominal organ, but here what you are having in this left supraclavicular area is the metastasis. And once lymphatics are involved, what is that? Stage 3. You're understanding? Metastasis is there. So it is now stage 3. By the time it is identified, by the time the person could realize something is happening to me, so that person is having stage 3 cancer because of the spread of the cancer cells via the lymphatics. That's why lymphatic drainage of the stomach is very, very important. So it's very easy. You will draw a vertical line dividing the stomach into right 2/3 and left 1/3, the imaginary line this is. So here you have got the outer end, the fundic portion, the posterior area, and little portion of the anterior surface, the left 1/3. What I am trying to show here is drained by the pancreatico-splenic lymph nodes. Via the splenic vein, they reach the celiac lymph nodes. The lower portion of the left 1/3 of the stomach, it is drained by the right gastroepiploic lymph nodes, which is opening or draining into the subpyloric lymph nodes. The subpyloric lymph nodes, they drain into the hepatic or directly into the celiac group of lymph nodes. Whereas the right 2/3 is draining into the gastric lymph nodes. From the gastric lymph nodes, again it will go to the celiac lymph nodes. Coming to the pyloric region can directly drain into the celiac lymph nodes, or it can go into the subpyloric lymph nodes. From the subpyloric, it can go into hepatic or celiac group of lymph nodes. Are you understanding? So this is the importance of the lymphatic drainage of the stomach. Okay, so the left supraclavicular lymph nodes are called as the signal lymph nodes because they are signaling that the primary organ which is attacked by cancer is in the abdomen, and this is called Troyer's sign. What is this called? Troiser sign. So lots of fancy terms you will learn in anatomy. So please keep on repeating them so that they will last long in your memory. Okay. Now we will go with the nerve supply. Nerve supply, for you to know, it's very important because we said from the stomach, which is also called gaster or venter, you got an adjective gastric ulcer. Now what is gastric ulcer? Along which curvature is gastric ulcer common? We are going to learn. And one more thing I want to tell. The cancer of stomach is common along the greater curvature. So along the greater curvature of the stomach, the carcinoma or the cancer is very, very common. Okay. And in which blood group you think this is common? Now I know. You have to find it out and let me know. Okay. In which blood group is this common? Now let us go with the nerve supply of the stomach. So when we are talking about the nerve supply, okay, so we have to go with the sympathetic and parasympathetic nerves. Now what are the sympathetic nerves which are supplying the stomach? They are from T6 to T10 spinal nerves. The 6th thoracic nerve, 7th thoracic nerve, 8th thoracic nerve, 9th thoracic nerve and 10th thoracic nerves, these are all supplying the stomach. Okay. How? Via the celiac plexus and the hepatic plexus, via the greater splanchnic nerves. Okay. Via the greater splanchnic nerves, these are splanchnic nerves, these are supplying, okay, T6 to T10 via the celiac plexus and the hepatic plexus of the nerves. Now please understand, the sensation of the pain is because of these nerves. When I said sensation of pain, in which condition? The gastric ulcers. In the case of gastric ulcers, the patients, they feel lot of pain, okay, and that is because of your sympathetic nerves which are T6 to T10. Okay, what are they doing or how are they acting on the stomach means these are motor to the pyloric sphincter. To the pyloric sphincter, they are motor. What do you mean by motor? It enables the sphincter to contract. Sphincter will contract and it is inhibitory to the rest of the gastric musculature. It is inhibitory to the rest of gastric musculature. Okay, now what will happen with this? Imagine the sphincter is not allowed to relax. Sphincter is contracting. The sphincter will contract and the rest of the musculature, you know, they are slowly they are accommodating the food what you take. So what is happening? Filling of the stomach is happening. Okay. And when you talk about this pylorus, you know, pylorus is called gate guard. What are they called? Gate guard. What do you mean by gate guard? How come that guard is coming in the region of stomach? See, when you are understanding the anatomy, please try to correlate with in this issue with little bit of gastric emptying time. So when you are taking carbohydrates, you feel your stomach is full for 2 to 2.5 hours. But if you eat proteins, then you feel your stomach is full for 5.5 to 6 hours. But if you eat lot of fatty food, then till 7.5 to 8 hours, you feel your stomach is full. Sometimes you see when you go for a heavy lunch and you have ate very well, you had a ball, then you say in the night I won't eat dinner. Why? Because the fatty food which is present in your stomach, it is not allowed by the pylorus to move out into the small intestine because that needs to be digested. That needs to be churned and then only that chyme will move into your small intestine. Are you understanding? So your filling of the stomach is by your sympathetic nerves where they are motor to the pyloric sphincter enabling it to contract, okay, and it is inhibitory to the rest of the gastric musculature. So there is slight distension, okay, there is slight that is the distension of the stomach to accommodate the food, and again these musculatures they are all contracting, okay, that is the churning of the food will start. Now coming to the parasympathetic nerves. Now what are the parasympathetic nerves? Obviously you know it is vagus. The vagus, it is the parasympathetic nerves. the supply, the parasympathetic supply to the stomach via the esophageal plexus and the gastric nerves. Via the esophageal plexus and the gastric nerves, the vagus is supplying the stomach. And please understand, when you are seeing the rotation of the stomach, now this is the right surface, this is the left surface. And when stomach is rotating in such a style, the left surface will become anterior, the right surface will become posterior. The left is becoming anterior and right is becoming posterior. Okay. So we will just say that the stomach, if we are trying to draw the stomach, okay. So let us say that there is the right vagus and the left vagus. Now this is the left vagus and this is the right vagus nerves or the trunks which are supplying. So the left vagus nerve is supplying the anterior surface of the stomach through anterior gastric nerve. Through the anterior gastric nerve, the left vagal fibers, and through the posterior gastric nerve, the right vagal fibers, they are supplying the stomach. It's very interesting to know, please focus, the left vagus fibers, they are entering the anterior gastric nerve. You can also call them anterior vagal trunk, you can call, okay. Generally for easy explanation we use the anterior vagus or the left vagus. So here it is entering, okay, here it is entering into the abdomen, and here it is giving the branches to the fundus, is giving branches to the lesser curvature, it is giving branch to the liver, and that is the hepatic branch, and it is giving a branch to the pyloric canal and the pyloric antrum. This branch which is supplying the pyloric antrum and the pyloric canal, it is resembling a feet of a crow, crow's feet. Now you know crow, it is the vehicle of Lord Shani Bhagwan. Okay, the Lord Shanishwar Bhagwan who is there, his vehicle is the crow. So it is appearing as if it is the feet of a crow. That's why you are calling it the appearance of the anterior gastric nerve or your anterior vagal trunk or the left vagal trunk supplying the pyloric antrum and the pyloric canal. It resembles the crow's feet. Also you have got the hepatic branch and the branches which are supplying the fundus and the body. These are called the nerve fibers of Lathargit. So what are they called? The nerve fibers of Lathargit. Okay. Now if you take the posterior gastric nerve, or which is having the right vagal fibers or the posterior vagal trunk, also you can call it, okay. If you see the posterior vagal trunk, I am using green color, but actually you should use yellow only. So if you see the posterior vagal trunk, the posterior vagal trunk is giving a very significant branch to the fundus of the stomach, and this is called nerve of Grassi. It is called nerve of Grassi, which is giving it to the fundus. Which one? The posterior vagal trunk or the posterior gastric nerve. The posterior gastric nerve which is carrying the right vagal fibers. It is also giving branches to the lesser curvature of the stomach to the body, okay, and these are called again nerves of Lathargit given by the posterior vagal trunk, okay. It gives one branch to the celiac ganglion. This is the celiac branch which is going to the ganglion. This is the celiac branch, okay, and here it is giving so many fibers. What? The right vagal trunk or the posterior vagal trunk. These are again called the nerves of Lathargit. Are you understanding? So you are having both the anterior and posterior vagal trunks or the vagal fibers which are supplying the body, the fundus, the pylorus of the stomach. Please understand, there is a very important question called vagotomy. What is vagotomy? Cutting off the vagal fibers is called vagotomy. Are you understanding? In case of interactable gastric ulcers. Now what are gastric ulcers? The ulcers which are formed at the lesser curvature of the stomach are called the gastric ulcers. Basically, the stomach is having a lesser curvature which is more prone for gastric ulcers, and it is having a greater curvature which is more prone for cancer. This greater curvature is more prone for cancer, especially in the people who are having blood group A. If somebody is having blood group A, these people who are having blood group A, they are more prone for carcinoma of stomach, which is along the greater curvature. But if you see the gastric ulcers, they are more common along the lesser curvature. Why ulcers are more common at the lesser curvature? Because the lesser curvature is shorter in length than that of the greater curvature. Okay, we have learned it. Greater curvature is 5 times longer than the lesser curvature. So the wave of peristalsis will stand here along the lesser curvature for a longer time. The wave of peristalsis will stand here along the lesser curvature for a longer time. That is one reason for gastric ulcer. Secondly, because whatever we drink will directly go to the lesser curvature, the mucosal insults by the irritating drinks which we are taking, maybe alcohol, maybe too much of thumbs up, Coke, Pepsi, these kind of things, or maybe too much of hot coffee, hot liquids, these are all going to irritate the gastric mucosa, especially along the lesser curvature. And people who are going on for very spicy curries, lot of chili they are taking in their food, they are all having chances of getting gastric ulcer, especially people who hurry, okay, and who are going on worrying. These people, they are having chances of developing gastric ulcers. And if you see, the nerve supply is more along the lesser curvature, so the pain what the patient perceives is more. We said these are the celiac plexus and hepatic plexus, these are large plexus of the nerves, and pain is because of the sympathetic nerves. There is a local spasm of the musculature here, and that will cause lot of pain. It is the patient is helpless, he is just taking some medicine and lying down because of the pain in the epigastrium. Okay, and also the blood supply relatively it is less. There is no doubt anastomosis of left gastric artery and right gastric artery, but that anastomosis is less compared to the anastomosis around the greater curvature of the stomach. So these are the reasons, a few of them. And again, Helicobacter pylori infection also can add to this gastric ulcer. And you have to understand there is something called peptic ulcer. Now what is peptic ulcer? Peptic ulcer is the ulcer that is produced when there is more amount of pepsin that is produced, that will lead to ulcer. And this is happening in the lower end of the esophagus, stomach, in the first part of the duodenum, also in Meckel's diverticulum. If you are talking about this peptic ulcer, it is seen in the lower end of esophagus. Also it is seen in the stomach, also it can be seen in the first part of the duodenum, also it can be seen in the Meckel's diverticulum, and in people with blood group O. So when people with blood group O, they are more prone for peptic ulcers, whereas people with blood group A, they are more prone for cancers. Now coming to vagotomy, there is something called truncal vagotomy. So where the trunk of the vagus nerve is cut. So when you cut here or here, that is called the truncal vagotomy. You're understanding? And second comes selective vagotomy. Selective, you are selecting where exactly to cut. Imagine you are doing selective vagotomy of the anterior gastric nerve or this anterior vagal trunk. If you are cutting after the hepatic branch and after the branch which is giving the crow's feet. So if you cut here, okay, that is distal to the branches to the hepatic and to the pyloric portion, then this is called selective vagotomy. In the same way, if you are cutting the if you are cutting the posterior vagal trunk, after this branch which is giving to the fundus, that is nerve of Grassi, and after the branch which it is giving to the celiac plexus, now here if you cut, then this is called selective vagotomy. Then there is another term called highly selective vagotomy. What do you mean by highly selective? You know, there is ramification of these vagal nerves, and these vagal nerves, they are supplying the parietal cells or the oxyntic cells, which are responsible for the production of HCl. So only those fine fibers are cut so that these parietal cells are not, or oxyntic cells are not supplied by those thin delicate vagal fibers. Then they call it as highly selective vagotomy. You are understanding? When you start cutting the trunks, so here the lots of damage can happen when you do truncal vagotomy, because the vagus nerve supplies so many organs, so many regions of the body. So this is called a truncal vagotomy. Now we are not going to do any truncal vagotomy, but we are going to go for selective or highly selective vagotomy. So in selective vagotomy, those branches, so from the trunk we first trace the branch. Acha, you are trying to do the anterior vagotomy, so that is anterior selective vagotomy. So you will go with the trunk, see, acha, there is a hepatic branch, now there is a pyloric branch that is supplying the pyloric antrum and